Hello, my name is Kento Shionoya from the Department of Gastroenterology and Hepatology, Tokyo Medical University in Tokyo, Japan. I'm very pleased to introduce our recent study published in Gastrointestinal Endoscopy entitled Efficacy of Splinting Tube-Assisted Duodenoscope Insertion in Patients with an Inaccessible Major Papilla, a single-center retrospective study. As you know, ELCP plays a crucial role in the diagnosis and treatment of pancreatic biliary diseases. However, insertion of the duodenoscope can sometimes be extremely difficult because of anatomical factors such as gastric deflection, duodenal deformity due to osseous or displacement after hepatic surgery. When insertions becomes difficult, excessive manipulation can increase the risk of serious adverse events, including perforation. Several alternative techniques have been reported, for example, the large balloon ankle technique or guide wire assisted methods. But these often require additional devices or advanced skills. Therefore, we sought to evaluate a simpler and more accessible approach using a splinting tube, which is originally designed for colonoscopy to facilitate duodenoscope insertion during ELCP. We reviewed 8 patients who underwent splinting tube-assisted duodenoscope insertion between March 2024 and March 2025 at our hospital. All patients had non-altered anatomy, but experienced difficult scope passage due to anatomical deformation. When student maneuvers such as abdominal compression or guide wire assisted methods failed, the splinting tube was attached to the duodenoscope to reduce gastric looping and straighten the gastric axis. This allows smoother advancement from the pyloric ring to the descending duodenum. We evaluated technical success, clinical success, procedure time, and procedure-related adverse events. Technical success was achieved in all 8 patients, and clinical success in 7 out of 8. The median procedure time was about 45 minutes, and no procedure-related or delayed adverse events were observed. The causes of difficult insertion, including gastric deflection in most cases, duodenal ulcer-related deformation in 2, and gastric displacement after left hepatic lobelectomy in 1. Interestingly, even in cases where multiple advanced techniques had failed, the splinting tube-assisted method succeeded immediately after introduction. Our results suggest the splinting tube-assisted duodenoscope insertion is a safe, effective, and practical troubleshooting technique for ELCP in patients with difficult duodenal access. The tube provides mechanical advantage by stabilizing the gastric axis and transmitting forward force efficiently, minimizing loop deformation. Unlike EUS-guided biliary drainage or percutaneous drainage, the technique does not require special expertise or expensive devices and can be performed using standard ELCP equipment. It may serve as a first-line troubleshooting step before considering more invasive alternatives. Moreover, this technique may reduce the risk of perforation by avoiding excessive force during scope advancement. Although our study was limited by small sample size and retrospective single-center design, it represents the first study to evaluate this method specifically in patients with no surgically altered anatomy. Given its simplicity and cost-effectiveness, we believe it can be easily adopted in routine practice, even by less experienced endoscopists. In conclusion, the splinting tube-assisted technique offers a simple and safe solution for difficult duodenoscope insertion during ELCP. Future prospective multi-center studies are warranted to confirm its effectiveness and define which patients would benefit most. Thank you very much for your attention, and I hope this technique will contribute to improving safety and success rates in ELCP worldwide.